Hi, everybody. For this week's clinical conference, we have a 7-year-old female, GH, who was originally admitted April 12th, 2021, with a past medical history of short gut syndrome, G tube dependence, liver failure, and requiring a liver transplant. And this patient was consulted to the pediatric liaison service for concerns of agitation and aggression. The issues they've been having with this patient is he's been hitting the nursing staff. He's been very provocative and sexual with his statements as well as with his behavior. He's only 7. And so they wanted help with that. Um, this, our service has been involved with this patient for many months, and this is actually one of the multiple um, consults that we have had for him. So this is a long-standing issue. This patient is currently on 1 milligram of risperidone twice daily for agitation and aggression, and as well as he has multiple PRN medications for his agitation. His first line is a zero point 0.5 milligram risperidone. Second line is Klonopin 1 milligram PRN, and then daily. And then the third line medication is 2.5 milligrams of Zyprexa PRN daily. So he definitely is struggling with agitation and aggression. So on assessment, when we went to see the patient, he showed some signs of hyperactivity. He 1 second was pulling out the IV pole out of the wall, and then the second he was on the bed, and then from the bed he jumped off the bed and wanted to show us the fort that he made with sheets. He's extremely hyperactive. And my preceptor, as well as the attending physician, felt that this patient met the criteria for ADHD given his behaviors and this longstanding issue of hyperactivity. So we started him on methylphenidate in the transdermal form because of his history of short gut. We were concerned about um, absorption issues. So this patient was started on methylphenidate, 10 milligrams, in a 9-hour patch. And his teacher did notice some improvement since they started the medication. He's much better with finishing activities that are age appropriate and cognitive appropriate for children similar to him. He's doing much better with that. However, his behavior still continues to be escalated, and so we're continuing to manage that at this point. So for his mental status exam, his general appearance, he's a small African American male with a distended abdomen and jaundiced skin and eyes. He's dressed in a hospital gown and walking in his room with an IV pole. His motor behavior, his gait is smooth and even with no abnormal movements such as tics or bradycardia. His speech is fluent. The amount is increased. The rate is fast. The tone is irritable and the volume is loud. The mood, he said, is fine. For his affect is irritable and agitated. His thought content showed no signs of suicidality or homicidality, obsessions, or compulsions. His thought process is linear, organized, and goal oriented. His cognition is A&O times 4 with long term and remote memory intact. His insight was poor due to his age and limited understanding of his diagnosis, but his judgment has been poor given his provocative and aggressive behaviors with staff. So for his diagnosis, access 1 is ADHD, access 2 is deferred, access 3 is short gut and end-stage liver disease, access 4 is patient has had a history of abuse and neglect, and the parents no longer have custody of him, and access 5 is 75. So for my reference today, I used the child and adolescent Lewis psychiatry book, and it says that maltreatment and other direct traumas during childhood significantly increases one's liability of lifetime psychopathology. And we can see with this patient, he's suffering from that. And Lewis also suggested starting a stimulant with patients who have been diagnosed with ADHD to help with aggression. All right, let me know if you have questions. Bye.